My name is Louis Carr, and I will be your moderator and host for today's webinar, Improving Patient Care Outcomes through Real-Time Connected Healthcare Analytics. This is part of a webinar series on healthcare analytics, data management, and integration that we're putting on here at Actian. So today we're going to have two panelists who will present to you some of their thoughts on healthcare analytics. We will start with Dr. Sandesh Prabhu, who is the Area Vice President and Head of Pre-Sales and Solution Group for the Life Sciences and Healthcare vertical within HCL Technologies, a global systems integrator. The area that Dr. Prabhu covers is healthcare and life sciences, and he has an organization that works with customers for life sciences and healthcare industries with over $1 billion in revenue just for that sector. After Dr. Prabhu speaks, we'll have Tim Casey. He's the CIO for Allegheny HealthChoices Incorporated. AHCI is a organization in Ohio that covers behavioral health innovation, and he will speak at length. After that, we will move over to questions and answers. We won't be able to answer questions during the actual presentations in order to ensure that we finish in a timely fashion and have time for everyone's questions. If we don't get to one of your questions, please rest assured that we will answer your question in email after the fact, because we expect there will be several questions and we unfortunately will not be able to get to them all. Once again, my name is Louis Carr and I'll be your moderator, but at this time, I'm going to turn it over to Dr. Prabhu. Dr. Prabhu?
Thank you so much, Louis. Hi, everyone. Thanks a lot for taking out time to be with us today in these difficult times. Hope everyone is staying safe. As you all know, any industry you take, one cannot talk about outcomes without talking about data and analytics. And healthcare is no different. In fact, both outcomes and data are coupled much more tightly in healthcare than anywhere else, given the wide variations we see here in healthcare. In fact, patient care outcomes are now a direct function of the healthcare data and the analytics that are driven by that data. And in our experience, sophistication and completeness of this healthcare data is extremely critical in ensuring that the best possible care decisions are made at the right time for the right patient and in the right care setting. In the next 15 minutes or so, I'll be talking about evolving definition of healthcare data, how this puts the data value chain under strain, what are the key tenets of a modern healthcare data strategy, and what kind of outcomes are the leaders driving today by adopting a data-first strategy to patient outcomes. So all of us, who have spent the last decade or more in the healthcare industry have witnessed the superlative growth in healthcare data volume, but that is almost always the talk of the town as well. However, that's not just it, right? So what is more interesting in the context of care outcomes is not the volumetric expansion of healthcare data, but the sheer evolution of what constitutes this healthcare data. And as you can see on the slide, if we started with the innermost circle, slightly more than a decade ago, right, the healthcare data meant clinical or medical records data, demographic data, operational data, and financial data. But then we were all hit by multiple legislations, starting with the ARA High-Tech Act of 2009, and the various compliances that came with that, and the initial wave of the so-called digital technologies covering mobility, cloud, social media, etc. As a result, we started adding social media data from continuous inpatient monitoring, population level health data, as also the patient survey data in the early part of this decade to the definition of healthcare data. As we progressed our march through the digital revolution in last 3 to 4 years, if you look at it, patient-generated data, genomics, and behavioral data, and more recently, social determinants of health became available more easily and are now part of what we call healthcare data even before we knew that happened. Just a few months back, again, we thought that we now had a comprehensive set of data elements that influence health, which constituted healthcare data. However, that was not to be. Coronavirus, as all of you can appreciate, has now decided to make its own contributions to the definition of healthcare data by making individuals' location data and movement data, travel history, an important aspect of this data spectrum. So with that background, if you move to the next slide, so as we saw, right, the healthcare data as it expands and evolves, there have been constantly uh, newer opportunities that are coming up, and they bring newer challenges with them. This is putting considerable strain on the entire data value chain in most of the healthcare enterprises, all the way from data collection, integration, and interoperability to aggregation, performance management, and advanced analytics. Newer data brings newer standards and the way they are shared. This is increasing complexities related to integration and interoperability. With increased sources of data and volumes associated, managing such big data in a safe, secure, and compliant fashion is a big headache as well. While on one side there is need to manage this big data, on the other side, there are ever increasing expectations on the performance of that data. Consumerism of healthcare and emerging care models like ACOs, clinically integrated networks, and even telehealth are now emphasizing on real-time reporting, self-service analytics, and such superior information and decision delivery. Ever-changing regulations and compliance requirements are not helping either. While everyone wants the cool data science leverage for precision and personalized medicine, we are still plagued by data quality, availability issues, and lack of clarity related to data ownership and monetization. So how do we deal with these challenges? So if we move to the next slide, so we see that many of the healthcare organizations today are trying to address these issues, most of these issues in their silos. However, to truly make the data work for the enterprise and for its stakeholders, including patients, it is important to have a comprehensive modern data and analytics strategy in place. The slide here gives you a sample reference architecture that strives to build such a unified data platform. So what are some key components of such a robust modern data strategy? And based on our experience, some of these are API-led integration interoperability to bring together all kind of data from various sources, traditional and non-traditional. That's going to be big. And readiness is of utmost importance on that front as more and more data becomes available. A cloud-hosted data lake, which is secure and high-performing, that's the next important aspect. While often forgotten or not addressed issue is the DevSecOps methodology while driving an agile data operations and platform management approach. So we strongly recommend that to be part of any data strategy that we adopt in healthcare. A robust data transformation with a focus on superior clinical data transformation. I highlight that clinical data transformation in an ELT versus ETL mode for efficient data processing is another cornerstone that one needs to follow. Self-service and point-of-care performance focused analytic services that are delivered in an end-user friendly fashion. But last but not the least, it is extremely important that these data and analytics utilities are then delivered within the workflows rather than as separate applications. So we will see, what it means to adopt this comprehensive modern data analytics strategy and what kind of outcomes, our partners are driving by adopting such a strategy. If we move to the next slide, the holistic approach to the strategy that we just discussed, when executed in the right fashion, almost always ends up addressing expected outcomes by all stakeholders, patients, healthcare professionals, and healthcare enterprises. I have listed down a few of them here. Again, this is not exhaustive or exclusive, but what we have tried to capture here are the common outcomes that our partners have driven, leveraging such a end-to-end strategy. A personalized, convenient healthcare for patients, which is safe and efficient and timely. For healthcare professionals, ability to make right decisions at the point of care, leveraging predictive healthcare. Better care coordination and ability to drive personalized care delivery for better outcomes. For hospitals and health systems, the benefits are a lot. However, just highlighting a few here, starting with better clinical outcomes like reducing readmissions, better reimbursement, efficient operations, and overall better engagement with the stakeholders like patients and employees are some key outcomes that we are seeing on the ground. Well, health plans are, are able to drive better cost management, fraud and abuse reductions, and more meaningful engagements with members and providers. However, the biggest advantage we also see, if you go back to that slide, um, we are seeing with the modern strategy is that it reduces the enterprises for both inter and intra-industry collaboration, which is increasingly becoming a reality. It's not just about healthcare and life sciences. Even beyond the healthcare and life sciences industry, we are seeing the collaboration that is becoming increasingly important. We'll see in next few minutes how some of these outcomes like reduced errors, better clinical outcomes leading to reduced readmissions, improved utilization, etc., all achieved by our esteemed panelist, Tim Casey, CIO of one of our partners, Allegheny HealthChoices. We'll also see how some of these are helping in the new world of COVID-19, in terms of risk stratification efforts. But before I hand it over to Tim, I thought it is only logical for us to look at some of the trending use cases that are enabled by real-time connected analytics that are directly driving better patient outcomes. I have broadly bucketed them into 4. There are more, but let's see each of them quickly in the interest of time. The point of care clinical decisions and ongoing monitoring. Two key use cases that we see having maximum impact on better patient outcomes are around patient 360 available at the point of care and the automated continuous monitoring and alerts that enable timely interventions. Similarly, if you move to the newer care models like remote health, the wearables and consumer grade medical devices have changed the equation and have been able to help us with a better wellness, prevention, and health maintenance management. So similarly, home health is taking off in a bigger way, and use cases like medication adherence are becoming much more easier to manage when compared to in the past. The third bucket, which talks about how reactive healthcare has become more proactive and predictive. The classic examples here are the smarter and intuitive workflows enabled by AI ML, both clinical and non-clinical workflows, as well as some of the proactive interventions and the risk stratification and next best action that are enabled by data science. We'll also see how this applies in a COVID-19 situation when Tim talks about that. The last one, which we just touched upon, was the cross-industry collaboration. And the point that I wanted to highlight here is the data democratization that's becoming increasingly accepted in healthcare. And that is expected to drive a lot of data sharing and aggregation among providers, payers, life sciences to start with, before it gets into other industry collaborations, and we expect better intelligence and insights being driven for better collaboration and coordination. So with that, brief context setting and a preamble, let me hand it over back to Lewis. Lewis, please take it forward from here.
Thank you, Dr. Prabhu. I thought that was fascinating. I can't wait till we get to Q&A to discuss that a bit more. But at this time, we're going to have Tim Casey, the CIO for AHCI, discuss real-time healthcare analytics. Tim?
Lewis, thank you. Hello, everyone. I'd like to give a shout out to John Papagni. He better be listening. Today, I'm going to try to talk about a little intro of who we are and what we do at Allegheny HealthChoices, our data warehouse development, especially how Actian was key in that development. We're going to talk a little bit about our analytic model that we use and address some couple topic areas of readmissions and Medicaid expansion, as well as our COVID response. And lastly, we're going to talk a little bit about predictive modeling. So Allegheny HealthChoices is a 501c3 nonprofit. We were formed in order to help implement managed care in the state of Pennsylvania. We're in Pittsburgh in Allegheny County. Behavioral health, if you're not sure, is comprised of both the mental health diagnostics and substance abuse. We were formed in 1999. An important point to realize is that on the continuum of data use, BH system or behavioral health systems tend to lag quite a ways behind regular healthcare. I would say that regular healthcare hasn't been great either, but behavioral health is always behind. One of the reasons, I think, is because the information is super protected, right? Of all the information that needs to be protected, the stuff that we handle is what we call Pennsylvania super protected. Our organization mostly focuses on quality assurance, monitoring of the program, but a big component is data integration and analytics. You can flip to the next. From a connectivity point of view, just so you can kind of get an idea of the scope, we're sitting in the middle at Allegheny HealthChoices. Our program receives kind of insurance files, mostly eligibility files that are related to Medicaid from the state of Pennsylvania. And all of this gets interwoven and integrated into our warehouse. As you can see on the left is the insurance company or managed care organization, and that is the operations of the insurance. Below are county partners that we work with, and this connectivity enables us to get access to data that's not specifically a part of the Medicaid program. So things that we'll talk a little bit about more specifics in a minute. And to the right are the actual providers of the service. So these are the people that are on the front lines, and from a data point of view, probably the big growth area as we start to move forward. All right, next. So big question when we first started, which was in 1999, there were really no examples of kind of data integration, data warehouse development in any behavioral health system that we were well aware of, especially public sector. So the main question was how do we integrate the managed care insurance functions, eligibility, auths, claims, quality and outcome data, not in and of itself, and then how do we integrate that with regular public sector human service data that's maybe state run or maybe county run, but examples would be like children and youth, jail, homeless, etc. And then in Pennsylvania, it should be mentioned that two systems, physical health and behavioral health, are in effect separate. We call it a carve out. We might be one of the few that still do this, but it's not one single source. So your physical health data is one system, your behavioral health system is another. And so we needed to come up with a solution on how to integrate the PH, physical health, and BH, behavioral health data. And the tool that we started using, and Lewis will get mad at me, I like to call Data Junction because that was the original name, but Data Connect, Actian Data Connect really made this all possible. And it's something we continue to use to this day. Next, please. Mentioning that Data Connect central to our ETL processes. It's used for all data that comes into the warehouse. So whether it's all those things on the chart that was just visible, all the partners, all of it comes through Data Connect into our warehouse. And I mentioned we would not be there without it. And a key thing that I have to mention, and you can leave that slide, Lewis, that's fine, is behavioral health public sector doesn't have a lot of money. So we have to figure out ways of doing integration with large scale data. And we needed a tool that would allow us to not have to hire people. You know, you get a couple people up to date. And it is really easy to use and has really been a great success for us. This is our analytic model that we try to use in behavioral health. At the bottom is kind of a recovery idea, the idea of recovery. But starting off, it's prevention, which kind of leads to people coming into the system, which is access. You know, are services available? Are they located close by or nearby? Availability is slightly different, is that even though a service might be nearby that you can get to, can you get in, right? A key question is a difference between access and availability. And then we start to focus on the actual service delivery, initiation. A key to any healthcare service is kind of a stable, repeatable service, which somewhat differentiates them from physical health. So if you're someone who has depression or someone who has a substance use disorder, a key part of a successful outcome is a stable treatment, right? So you need to get in quick, then you move to engagement, and try to make coming to therapy or coming to whatever that service is something that you'll find productive, and developing kind of a team approach between you and a case manager or a therapist. Then we're looking at stability of service. Oftentimes, behavioral health system is characterized by, these folks are poor, so they're not easily, it's not an easy process necessarily to get someplace else and to repeatedly get someplace else and to really take advantage. So we take a key look at whether the service is delivered in a stable, repeatable way. And then we start to look for people who, just because you've received treatment in the short term doesn't mean, the input from the system should go to zero until the next need crops up. So we focus on perhaps a titration down in the service delivery. Go ahead, Lewis. That's fine. These are the impact variables that we attempt to look at. We don't attempt, this is what we do, but it kind of mirrors well with some of the slides that Dr. Prabhu mentioned, but we're really trying to do that kind of overused analogy of looking at the whole person. As I'm surprised, and maybe for a variety of reasons, I don't know, but traditionally people went and got their physical health treatment and went to got their behavioral health treatment, and the two systems really not only didn't really kind of talk to each other or cross over, but absolutely didn't share data related. So you basically had someone carved in half that we couldn't take advantage of kind of the data systems that were in place and will be in place. So these are the variables. We're looking at physical health. We're looking at social and geographical impacts, personal history. So whether someone has a trauma, early childhood trauma, is a key variable that determines long-term service utilization, and also impacts of the healthcare system in and of itself. Are there limitations put in place by just the structure of the system? For example, is the number of inpatient beds, just the fact that they're available, and this question is kind of moot, it answers itself. What is just the fact, is having 100 beds there or 200 beds, what is the real impact of just that fact? Not based on need, it's just, what's the size of the system? The key one, that I always find that I think is probably the most important one, that's kind of a key to the reason why we did some of this webinar, is the impact of time. As probably most of you know, we have not been good at of using time as a key variable. And what that means is most data is retrospective look. You have a service delivered, a claim is submitted, that claim is adjudicated, that claim comes back into analytical tools, and looking back at when that first service was delivered, the world has changed, that person has changed. So what we're all trying to head towards, Actian and the work that we do, is how do we enable and start to enable real time. So the models and some of the stuff that I'll talk about later is how does that, what tools can we use when we're getting events in real time? And that's going to be the key. Go ahead, Louis. You can go to the next one. Okay. So this is kind of the comprehensive picture, which is from more of a technical side. So we take all those data inputs on the left side, and the one that I like to mention is a pet of mine is that non-traditional one at the bottom. Is we get a lot of data, and most of the stuff that analysts tend to look at is things that are pretty traditional that you would look at. Is, are claims being paid? Are admissions? What are readmissions? What are admissions? What are lengths of stay? How is capitation? What's the financing related to it? But I'm much more interested in this idea of looking at maybe non-traditional variables. Is the fact that somebody lives in a particular neighborhood the most driving factor related to the success of their healthcare? Is the fact that they have to, they're too far from a bus stop, or anything that you could potentially think of? And what we're trying to do here at Allegheny HealthChoices is start to really look for those non-traditional things that might be the variables that make all the difference, and maybe move away from some of the traditional stuff. But moving in, some of the outputs from the warehouse is traditional OLAP stuff and reporting, but we also have GIS stuff, systems for geographical analysis, predictive modeling, web applications, and dashboarding, all as outcomes and tools to use to better serve our populations. Yes, go ahead, Louis, that's fine. So in terms of kind of specific use cases, there were kind of two things that we wanted to mention. One is inpatient kind of admissions and readmissions in mental health care. And an important thing to mention is our local environment has had, comparatively within the Commonwealth of Pennsylvania, historical high use of inpatient, and probably a variety of reasons for that, but the main one is a key medical and kind of behavioral health service provider as part of the University of Pittsburgh Medical Center is located here, and they receive lots of federal funding in order to be able to do research on vulnerable populations, and so having a lot of beds was probably part of that, and also if you have a lot of beds, they tend to get used, and so there's lots of beds here, so our use tended to be higher. Our goal when we first started out, and you'll see a chart in a minute that kind of shows that, was to try to reduce those admissions and readmissions while expanding community services. So in the behavioral health system, I don't know if, as some of you may know, there's been a big push to close state hospitals and move those folks into the community. And in addition to that, what we try to do is also take kind of the next level of care down that is restrictive, and that would be kind of regular inpatient service, and try to avoid the use of that. We had fears that when we locally closed our state hospital, that we put pressure on inpatient mental health utilization. And what we used was, we had intervened, and you'll see this in the chart. And Lawrence, Louis, you could probably just go to the chart, and then I can kind of just talk about it. It might be easier for people to see. So this is a longitudinal look at inpatient admissions from January 1999 to the present. And as you can see, when we first started out, there was certainly a climb up. New system, we weren't sure what was happening, but for 4 or 5 years, we definitely saw an increase of these inpatient admissions. So in 2004, we started to say, we got to start doing something about this, and instituted kind of programs and initiatives to be able to kind of get that down. And that red line represents when the state hospital closed. So of course we had some nice periods there where we were certainly trending down with admissions, and we were seriously concerned about what the impact of the closure might have. And but we had this data that kind of was right there, so people could use that. We needed to be able to say that. So working with the counties, we wanted to kind of make sure that that other services and alternatives were in place in order to kind of prevent a bump. And you can see a little bump that came after that, but there's been a downward trend overall. But what we need to mention was kind of a unicorn that happened in 2015. Was there was a shooting in a local mental health facility, and that's what happens when you panic. So there was a kind of a reaction to that shooting, and kind of consequently, you see that bump. But we seem to have, after that period, weathered it, and the downward trend continues. Go ahead, Louis. Yeah. Medicaid expansion is the other thing that affects everybody that was related to Medicaid. Of course, the states had the option of participating, but most did. And it was, let's say that before that, were attempting to analyze what we thought the impact was. And what we found, it fundamentally changed the system of care here. And what it did do was traditionally the highest claims, or kind of the highest dollar related to services, was inpatient mental health. But post Medicaid expansion, it became a SUD service, which was non-hospital rehab. And also at the same time, we have the opioid crisis occurring. And I don't know, everybody throws around epidemic, but the good news was that the Medicaid expansion allowed kind of the opening up of drug and alcohol and substance use services, and allowed the system to be able to pay a lot more attention to not only the influx of new people into the system who was primarily driven by SUD, but also adapting to the needs generated by the opioid crisis. So this was just a little chart that I threw together that since Medicaid expansion, the enrollment is actually higher than traditional Medicaid. So it was quite a significant impact on our on our system and continues to be. Go ahead, Lawrence or Lewis. Thank you. So you read the marketing materials, and it talks about real time, and I wanted to make sure that I covered real time, and what we're using right now predominantly as our major kind of the major example of real-time analytics is kind of an application data system related to community treatment teams, or some people call them ACT teams, assertive community treatment teams, which are a multidisciplinary wraparound service. So it's designed to divert people from inpatient mental health utilization. It's as I mentioned, it's a team that's comprised of docs and nurses and therapists and other clinicians, and they get a caseload, and their whole goal is to kind of keep people kind of where they're at and try to make sure they don't go to inpatient. And when we started this, and I apologize, I don't remember, like 15 years ago or something, but we developed a web-based app where these teams would input status information related to their caseloads, and we would use Data Connect to integrate that data. So that data would be more what you would consider kind of more clinical or more outcomes data. Today would most likely be in EHRs, or hopefully be in EHRs, but the data would be connected. And what happens is that stuff is all real time. So when something happens, community treatment teams enter it. The data gets integrated with stuff on the insurance side, so that will be predominantly claims and predominantly utilization of what services that are being used. You can go to the next one, Lewis. And then we use dashboarding to kind of measure how everyone is doing. And what you have here is kind of just a snippet of one team. I couldn't tell you which one it was, but so you have different kind of domains. Housing, crisis utilization would be a crisis service. So if you're, if you're having a crisis, there's a number to call, and people can rapidly come out and help you. Of course, there's inpatient, and then we place, certain bars on there in terms of that shows what's expected. But this data is actually updated in real time, so it's something that people can take advantage of and see it. And it also helps to start to integrate other data that was beyond kind of your traditional behavioral health system data. So in the bottom right is you saw your PCP, you saw your dentist, and started to integrate physical health data into it. How are we doing time-wise? All right, you can go to the next one. Okay, so last two things I'm going to cover is predictive modeling and COVID. And so, predictive modeling, machine learning, AI, buzzwords of the probably of the decade. And, for us, it gets down to the idea that it's just a way to make analytics more proactive versus reactive. Of course, that introduces variation, but it's something that we are committed to and have been working on for 5 years or so. And a key aspect of this, that the thing that we struggle with is not the math, and it's not the tech, and it's not the data. It's the ability to explain it to other people in an easy way. So you try to balance how well models do, how they perform, i.e., are they good at predicting a particular outcome or not? But which variables are making a difference, right? So if you throw the kitchen sink at it and let the machine work it out, are there things that are uncovered that maybe aren't as easy to explain to a care or case manager who has to kind of make a difference? But that's something that probably everybody struggles with in terms of modeling and things of that nature. But predominantly what we've traditionally looked at are predicting high utilization and predicting inpatient mental health admissions and readmissions. And in addition, we also look at the idea of critical or adverse incidents, which are incidents that generally you don't want happening. And we have a kind of a data system that collects those. And, you know, to help facilitate this, the model development, we're basically looking at $22 million, claims that are comprised of this. So part of this work was this idea of high utilization. And when I first thought about it, you know, everybody says this, you know, you have to pay attention to the high utilizers. It's all about the high utilizers. You have to bend the curve on high utilizers. And the thing that I ask myself is, who are high utilizers? Is it just a single group of people that are always high utilizers and every year, and so you know who they are? And, you know, are they in a position as the system technically able to serve them? Do they have the skills and the treatment protocols in order to be able to serve them? I said, or not. I mean, is it? And so the first step that we used was to try to really understand the dynamics of high utilization. And what we came up with was that it's not the same people every year. There are a small group that tend to be what we call career high utilizers, but it's a small group. And then a very large group are the people that will never be. And in between are groups that, one of them is called chronic and sporadic. Chronic are people who aren't every year, but might be, every other year, or, 3 years out of 4. And then the sporadic are, maybe 1 year, 2 years out of 5, or 1 or 2 out of 10. And to me, this was very enlightening. But what came after us understanding this, and why the idea of why we got to the point of being able to think about predictive modeling in a way that would really help in terms of high utilization and risk, was, how do we make this useful? And what's useful, ideally, is what you see on this chart. Is, generally one could argue that a way to deal with high utilization is basically just look at the people that were high utilizers last year and then intervene in that group. Now, from a mathematical point of view, my thinking is all I have to do is beat that. So, given the distribution of, it's not the same people every year, it was something that we came to and thought, we should be able to easily do this, be able to beat the idea of just paying attention to people who are high utilizers last year. So short story long, we generate scores of a probability matrix of, is someone likely to become a high utilizer in X period of time? And that data is then sent and transmitted to stakeholders in order to be able to use that information to be able to track kind of who to keep an eye on and when. A key aspect, I think, of all of this is, how do you know what to pay attention to, right? We're bombarded by stuff. And these tools start to kind of put a kind of a microscope or kind of a telescope or whatever better analogy you can come up with that I'm not using, and say, hey, if there's going to be people who are high utilizers last year and they look like this, who are not likely to be high utilizers this year. And there's going to be other people who weren't that are going to come in, and those people look like this. So it's really kind of starting to make a difference in how we do things, how care is administered, and the data that we use. Louis, you can go to the last chart. How am I doing time-wise? So we wanted to, be timely and include something for what we're doing vis-a-vis COVID-19, and what we're doing right out of the gate is starting to look at our behavioral health system and look for comorbidities in the physical health system, especially those comorbidities that make you more at risk if you were to develop or be infected by COVID-19. So a pretty simple graphic here. You're taking the behavioral health data, you're merging that with the physical health data, and what you're doing is then you have outcomes of analysis. And one of the things that we're going to try to do, and we have some results that came up this morning, was, potentially there's about 30% of our members are at a heightened risk due to COVID, and those are people then who have outlined what kind of those comorbidities are on the left. So that's diabetes, hypertension, COPD, asthma. Of that 30%, approximately 55% is due to hypertension. So it's and less, and a third of the group is asthma. So what we're going to do coming out of that is we'll start to then produce kind of targeted, this is where they live. This is the service provider that that's responsible for them. These are the things that they might need. Alerting, kind of geographically alerting providers, hospitals that there might be kind of a hot spot of where people live who might be at risk if they were to develop COVID. So it's something that obviously we're paying attention to, everybody is, but this is just one example of the work we're trying to do to help fight this off. So given that, that's what I got. And thank you for listening, and I'll return to Louis.
Thank you, Tim. I thought that was fascinating. So at this point, we move into our Q&A phase. We have, roughly 10 minutes to answer any of the questions that you might have. One of the questions is actually, it just popped up near the end, and that's probably because, Tim, you were talking at the end about this particular topic, and that is, with the predictive modeling, right? The idea is to take some baseline pattern of data, the better the pattern, the better the algorithm, the better you're able to model that and then tune it and then actually run it, the better your results will be. But the question really becomes, what do you do with the results? So you mentioned then one working example with looking at who are chronic users, or I guess that implies overusing the system. So how did you use that information? Did it provide a decision support question or direction, or can you be a little more, descriptive of that?
I can, yeah. Let me kind of give you what my end goal is, and then work back to kind of where we are on that continuum. So I'm a numbers guy, I'm a math guy, and I'm an IS guy, and I've always had this goal of developing these risk indices, right? So it's the idea that at any point in time, an individual can be assigned these scores that will give them absolute and relative risk vis-a-vis something, let's say a bad event happening, or an event that you'd rather not have. So high utilization was that, and that final risk score would be in effect comprised of what I would call sub-indices, or let's just call them sub-indices, that would be scores related to things like trauma, things like aggressiveness, things like inpatient utilization. There would be a few other physical health ones too. And in the end, all of it would be to have a mathematical, quantitative way to kind of view the person. And in no way, I'm sure if there's any clinicians on there, be like scared, but trying to deliver that information in a way that's helpful to the clinical teams so they can relate their own internal paradigms to say, yeah, all right, so Tim is a 7 and Louis is a 6, and I get that, right? Or Louis is a 4 on this indices, but he's an 8 on this one. I understand that. So what we're trying to do to answer the question is we're taking the numbers. So out of those high utilization models, our risk scores 0 to 1. 99 is you're absolutely going to be a high utilizer, and 0 you're not. And we're that information, in one example, we're working with our local insurance company to be able to work with clinical input to be able to say, the key question is how much do the clinicians need to know about what's behind the model, right? Which is a key thing that we struggle with. And the balance between a well-performing model and one that's easily explainable. So in the end, we're trying to move, and this is the steps that we're taking in order to take a number and assign it to a person that gives a clinician a measure of absolute and relative risk.
So Dr. Prabhu, one of the things that you showed in your presentation was a reference architecture, and it was quite broad and yet detailed, which means that in the glimpse of putting it up there, people started asking broad and detailed questions about it. So, you know, the thing about a data warehouse, whether it be for an organization of the size and resources of Allegheny Healthcare, or it's Kaiser, or let's say CDC, you know, most of what you would see over, you know, historically has been on premise for these data warehouses. And you had mentioned trying to move some of that to the cloud. And so the question was, you know, how realistic is this? How long would it take? What are some of the obstacles, and what are some of the benefits of moving a lot of this healthcare data, or at least the analysis of elements of it that you would have the rights under whatever your regulations and guidelines are to actually do that? So that's kind of the broad question.
Sure. Yeah, let me try to answer it at a high level, and then we can get to the details in a follow-up. But overall, you know, if you look at our industry, healthcare, and, you know, I'm including life sciences also into this. So we are expecting a drastic uptick in, you know, cloud adoption when it comes to data hosting, management, what have you, right? So, you know, if I remember that at the top of my head from the recent read, next 2 years, we are expecting a big uptake between 20 to 40% on a year-on-year growth from a cloud adoption in healthcare and life sciences. The different reports vary, but, you know, the range is somewhere there. And we are also seeing that the initial hesitation in terms of going to cloud from a privacy security standpoint, they are now being addressed both from a technology as well as from a business and compliance perspective. So that is giving much more comfort to our clients who are taking that path. While I say that, you know, the trend that we are seeing on the ground is that, you know, the adoption is both on the public as well as private cloud. So calling it more, making it more of a hybrid cloud strategy for our customers. And data and data management is one of the primary areas where this cloud adoption is taking place. So in terms of, you know, just to shorten the answer, if I can, so the privacy, security, and other compliance related aspects are mostly being taken care both by the cloud providers as well as by, you know, system integrators like HCL, and, you know, in working closely with clients. And the second aspect in terms of the time and effort, it varies by client to client really, and what part of the data that they want to move to cloud and what they want to keep on-prem. So that's a very difficult question to answer from a sizing perspective, but know that, you know, in next 2 to 5 years, you know, at least we are looking at majority of the data to be moved to cloud, you know, one way or the other. And obviously, you know, the volume is adding to that, variety is adding to that, the typical big data definition is adding to that. But more than that, I think, you know, the flexibility of being able to manage data in a remote fashion at the same time not losing out on the ability to compute and hypercompute to address the performance-related requirements as we do that are the biggest draws for healthcare to move to cloud.
Okay. All right. Well, thank you, Dr. Prabhu. Did you need to add anything to that, to Tim? Otherwise, I think we were able to figure out what, thanks to one of the people in the audience.
No, I mean, I think, let me go ahead. I want to say, except for kind of the standard HIPAA transaction sets and things of that nature, most of the interchange happens kind of not using kind of those standard sets, beyond kind of claims and auths and those kinds of things that are HIPAA governed. A lot of the information that we exchange with people or kind of stakeholders aren't governed, but I'm not aware of which FHIR data sources, but I would imagine that if they could be useful if I knew what they were, but I mean, I think it points to something that I think is important is, what are the data sources, what data is out there, what data can you use, and especially related to COVID, what data will become available for organizations like ours to be able to take advantage of it and integrate into our warehouse and be able to use it in the models. So
I see.
Great question that I was completely unprepared for.
No worries at all. And there's plenty of other questions, unfortunately, that we're not going to get to because we've run up on the hour. But rest assured, for the rest of you that are sending questions, we will answer them in email. And I want to thank all of you for taking this full hour, the time out of your busy lives, especially with the concerns that you're facing now. And hope that you have the opportunity to tell your friends to view this webinar. It will be on demand very shortly. And join us for the next episode in this series. With that, I bid you adieu. Thank you so much. And thanks again, Dr. Prabhu and Tim. Really appreciate all your time and effort. And it was very interesting.
Thank you.
Thank you. Thank you so much.